Hi, everyone. Today, I will speak about the foundational research and how the gender medicine establishment moved from transitioning mature adults to transitioning children and adolescents. And we'll discuss some of the limitations, briefly discuss some of the limitations of the research. We all know that youth gender transition has become a very, very hot political topic, and there is an assumption that there are two sides. There's a conservative, perhaps a Christian conservative side that is deeply against childhood transitions on religious grounds, and then there's the liberal side that is very open to this clinical treatment pathway, both for children and adults. What is really interesting is that actually the foundation of gender transition of adults, and it did start with adults before it moved on to children, was deeply rooted in Christian medical ethics. This has come as a surprise to many of us, but they were early intense discussions about gender transitions of adults because one of the most fundamental principles of medicine is that you do not cut into a healthy body. And so there are a lot of ethical discussions about whether or not it's appropriate. And the VU hospital, which became the center for youth transitions eventually, and still is sort of the worldwide most respected team conducting these treatments, was a Christian hospital. And the clinicians that took this issue on board early on were devout Christians, and they argued that this is very much similar. Well, first of all, they argued that compassion is a deeply rooted Christian value, and to the extent that there's a conflict between the body and the soul, there's a supremacy of the immortal soul over the mortal body. So that ethical conflict was reconciled through Christian ethics, and I think this is both, fascinating, contradicts some of the current claims, but also emphasizes that really the decision to help mature adults transition was deeply rooted in compassion. The goal was to alleviate suffering. Those were mature adults with years of failed medical treatments and ongoing suffering. And clinicians judged that it would be more compassionate and ethical to conduct to deliver or administer treatments that under other circumstances would not be considered ethical. The real focus of these 2 days is the treatment of adolescents, children, adolescents, and young adults. And I understand there is some argument about whether we can call 12-year-olds children if they initiated puberty. From my perspective, they're still children. The treatment of children and adolescents in the Netherlands was a direct follow-up to the first cohort of treated adults. So without going too far into the history of the Dutch treatments, there was a surgery. There were some surgeries that were done under the supervision of surgeons in hospital settings, but hospital administrators really did not know about it. Then there was a first official known surgery of a female-to-male individual, and it was published in a major medical journal. And there was major backlash. A lot of professionals were concerned with ethics. There are a lot of angry letters written, and the Dutch Ethical Council essentially, the treatments were effectively banned for some time. But then they resurged and became approved in the early 1970s, largely due to the work of the Christian clinicians in the hospital, as I described, who really were pursuing a compassionate approach to human suffering. The next slide will dive deeper into this first study of the Dutch outcomes, because I think the adult outcomes are very interesting, and it is very interesting that despite those outcomes, or perhaps precisely because of those outcomes, the decision was made to move the treatment age lower. But to cut to the chase, the outcomes, the subjective outcomes were good. The patients said they were very happy and they did not regret it. There was significant dropout rate, which was not considered, but those who did engage in the research did say they were quite happy with their decision. But objective outcomes, functioning in particular, was not good. Also, suicidality post-transition was quite high. And so It is not directly stated in the Dutch research, but it is clear just by reading the early studies and reading some of the rationale in the studies, early studies of treating adolescents, that there were these observations that the younger patients in these adult studies seem to fare better. And it appears that there was a leap made that the younger you are, perhaps the better outcomes will be. And there is some logic to that, because if you believe in the true transsexual concept, which was very prominent at the time, then you truly believe that the patients were born with what was considered almost like an invisible congenital defect, a mismatch between the brain and the body. And then why would you wait? Obviously, the longer you're trapped in this discordant body, the more trauma you incur, the more dysfunctional you become. And then when you correct that later in life, that's too little too late. And so there was a good rationale, if one believes in the concept of this true biological mismatch, that why would you wait? But I do believe that the observation that the younger patients, those younger than 30 in particular, that fared better in the adult research, did give some ethical justification to moving the age lower. What wasn't perhaps considered is that in that adult research, the younger patients were also biological females, and they tend to have gender dysphoria manifest about a decade earlier. And as a result, you could perhaps attribute causation to a correlation. Younger patients were females fared better. Therefore, perhaps the idea that all younger patients will fare better, as opposed to biological females will fare better, that perhaps was an erroneous conclusion, but that's not known. It is important to note that the risk of early transition was well understood by the Dutch clinicians. And really, there was intense focus on trying to identify those who are true transsexuals through differential diagnosis, ruling out many other factors that could lead a young person to develop gender dysphoria. And the three factors that I've listed below were sort of the key. There are many more, but those are the main ones that clinicians looked for. They looked for early childhood onset as opposed to adolescent onset. They looked for gender dysphoria worsening with puberty. They looked for complete cross-sex identification as opposed to perhaps a non-binary identification, which is becoming so common now. And the patient had to be free from significant psychopathology. So the practice of gender reassignment became legal in the Netherlands, and it was not technically legal before, but was effectively legal. It became both legal and, importantly, reimbursed by insurance in the early 70s. And in fact, private insurers in the Netherlands apparently were quite reluctant to cover these procedures, but public the national health system did cover it. And at the time, the Dutch clinicians advised mature adults who wanted to pursue gender reassignment to reduce their working hours in order to qualify for public insurance. The first outcome study was published in 1988. And if you do the math, it was about 15 years after the practice became legal and reimbursable by insurance. In reality, it was on average a 2 to 5 year follow-up for the patients, because of course, the early patients were very few. There were some people who had, 10 plus years follow-up, but most patients were very, very new to the treatment pathway. In fact, 40% of those in the study didn't even complete the treatment at the time of the study. There was a significant non-response rate that was not considered by the researchers, and that's a theme that continues on. We do not know what happens to the patients that fall out. But among those who did participate in follow-up research, there was subjective satisfaction. Nobody regretted it. Most people were at least somewhat satisfied, very satisfied. Yet their objective measures of functioning that the researchers measured did not improve. In fact, a quote from the study is actual life situation, improvements in actual life situations were not always observed. Another interesting observation that the researchers made and commented about is that improved life satisfaction was not related to stage of transition. So those who were just starting the treatment were just every bit as satisfied with their lives as those who already completed or those that were midway through. And the researchers thought about what this means, and they described state of mind of the patient of perhaps taking a loan on the future. There was also a finding from the research that emerged that the researchers themselves called a critical signal, and that is 1 in 7 of male-to-male participants and 1 in 36 of female-to-male tried to commit suicide after starting treatment. And so the conclusion from that research was quite sobering. They called the results equivocal findings, unclear if improved satisfaction was due to a true resolution of gender dysphoria, or perhaps patients being hopeful about the future. They used the phrase taking a loan on the future. And their conclusion, and this is quote, sex reassignment surgery is no panacea. Alleviation of the gender problems does not automatically lead to a happy and lighthearted life. On the contrary, SRS can lead to new problems. Because perhaps despite the study, or maybe somewhat coincidentally, a leap was made from adults to youth. We can speculate about the leap. It would be wonderful to hear from the Dutch team more directly what the thinking was. A lot of the people are still very much in prime of their careers. The book that I'm referring to by Alex Baker has detailed interviews with each of the clinicians, so you can hear directly what their thoughts were at the time. The first bullet is my conclusions. The next two are derived from the book. It does seem that, and early childhood studies from the Dutch clinic, child transition studies or adolescent transition study, do talk about the adult studies demonstrating or suggesting that early age of transition is beneficial. As I mentioned, I am personally wondering perhaps what the influence, the significance of the fact that female to male patients tend to be 10 years younger, and those patients tend to be, in the early cohorts, tend to be much freer from psychopathology, as Dr. Levine also described and other studies showed, and whether there was a conflation there. But nonetheless, it does seem that the idea that younger patients fared better, not just in the Dutch research, but also in research from Sweden and other countries that were doing early adult studies, was informing the decision that perhaps going upstream, early intervention is a good idea. There is a significant amount of chance or happenstance. The psychologist who was working with trans-identified adults, Peggy Cohen-Katanis, and my understanding is that she was not assessing the adults for the fit, for whether it was appropriate for them to transition. That was done by others, but she worked on psychological problems of trans-identified people or transsexuals. She transferred to the children's division in the hospital. And she said that at the time, she thought this would be the end of her work with transgender patients once she stopped working with adults. But once she began to work with kids, she began to see a lot of kids. And she refers to so many born girls who lived as boys who hit a wall with therapy. And there was another chance encounter between her and the endocrinologist who was in the Netherlands, who was treating what some refers patient 0 with puberty blockers. It was an endocrinologist. Previously, only progestins were used to suppress menstruation in girls, and puberty GnRHAs were not used. But this endocrinologist had a great idea that puberty blockers are much more impactful. And the boyish appearance of that first patient, who did not go through most of the female puberty, really made an impression, the physical appearance, on Peggy. And she writes, this is again from the interviews in Alex Baker's book. And so Peggy, I believe, made the decision. Perhaps it was a team-based decision, but the decision was made not to wait till you're 18. What's the point? And it was lowered to 16. And then the introduction of, so for cross-sex hormones, age was moved from 18 to 16, because what Peggy described are that there is girls that lived as boys. They were very uncomplicated. She used the word uncomplicated, just very straightforward, free from psychopathology. They had clear male identities. Why are we making them wait until they're 18? Let's start at 16. And then with the introduction of puberty blockers, which other speakers will talk about later, and the importance of that step, then the ages begin to lower to 12, and now we know it's even lower. The decision was supported by the endocrinologist at the clinic. So I'll briefly review the Dutch protocol. Most of those interested in the topic know about it. The treatment at the time was puberty blockers. In the protocol, it states age 12. In the foundational studies that supported it, it was actually 15. Cross-sex hormones, again, minimum age 16 in the protocol, much closer to 17 in the Dutch studies. And the Dutch law at the time required sterilization. This was necessary. The young people did not have a choice. We don't know how many were willing to. Today, there's more research from the Dutch clinics showing that a lot more patients are opting out of surgery now that this law is no longer in place. And in fact, the Dutch government issued an apology to trans people for these laws. But at the time, every patient had to be sterilized. And the minimum age for that was 18, and in the studies, it was 19. This is a very drastic treatment protocol, as you can see. And therefore, eligibility criteria were very tight. Again, they were focused on identifying true transsexuals. How did the Dutch team decide whether a patient in front of them was a true transsexual or not? There's a lot of, I'm sure, clinical knowledge and expertise that could not be codified just because they've seen so many of the patients that did well and then some who didn't do well. And there's probably a fair amount of clinical intuition that was developed by the team. But in terms of what was codified, it was early childhood onset. In fact, in the early research specifies from toddlerhood on, complete cross-sex identification, severe distress worsening with puberty, a clear understanding of biological reality. These children were required to know they will not be real boys or girls when they transition, but it will be as close of an approximation as possible, and strong parental support and the support of the greater network around the child was required, because it was understood that this is not an easy decision and the life of this young person will be challenging. I'll briefly discuss the results of the two studies that gave rise to the practice of youth gender transition. It's a 2011 and 2014 study. The 2011 study reported on 70 cases treated for an average of 2 years with puberty blockers. The study reported some improvements in some measures of mental health. The effect sizes were relatively small. There was no improvement as measured by the Dutch homegrown UGDS, gender dysphoria scale. It's a scale that the team developed, and I'll say a few more words about that scale. The conclusion of the study was very sober. When today so many clinicians say the Dutch research definitively proved it's such a strong study. Actually, when you read the study, this is literally the conclusion. Puberty suppression may be considered a valuable contribution in the clinical management of gender dysphoria in adolescents. It's quite sober and limited, I would say. The second study followed 3 years later. It was a subset of 70 cases. It was 55 of the original 70. They were followed on average 1 to 2 years post that sterilization, post that final mandatory surgery. The study reported complete resolution of gender dysphoria using UGDS scale. And that finding, I believe, is the reason why today the practice has become so ubiquitous worldwide in the Western world. However, as far as other mental health outcomes that are more standard measures of depression, anxiety, etc., using standard instruments that are used across a range of conditions, as opposed to instruments developed by the team specifically for their own treatment pathway, they were more limited improvements. There were some, about half the measures, there were improvements, and half they weren't. The improvements were of limited clinical significance, most of the patients remained in the same clinical range as before and after. There were improvements, they were statistically significant, but the clinical range for most measures did not change. And this is the verbatim conclusion. I will let you read it, but it's stronger. It's much stronger worded than the original study, but still, what I'd like to emphasize is the last part of this quote. So this treatment pathway gives an opportunity to develop into well-functioning adults. It doesn't say much more than that. And I will add that every single child was screened to be highly well-functioning at baseline. In fact, their functioning, it appears to be from a series of other studies surrounding this cohort, was probably not much worse or maybe similar to the average Dutch adolescent who did not have gender dysphoria. This is because of the clinical, very strict criteria used to screen the patients. I will briefly now talk about the limitations. We wrote a paper with Dr. Levine and Dr. Mason called The Myth of Reliable Research, where we went in detail. And so it's a paper with many pages. I will not take you through all the pages. I will try to just hit the highlights. The puberty blocker study, perhaps the biggest overlooked problem in the study, and we do think the studies have problems, and also we qualified our conclusions in our paper, and I want to repeat them. Our goal is not to undermine the Dutch studies. At the time when they were conducted, it was a groundbreaking research. The Dutch clinicians were reporting on a clinical practice as it was occurring. It was not set up as a trial. Okay, so this is the best they could do given the data that they had. Still, today we need to evaluate it through the lens of the rigor that would have been required to launch a practice with such a drastic treatment pathway into widespread use. So inadvertently, the Dutch researchers ended up with a significant selection bias that I don't think is, to this day, is well understood. In order to qualify for the puberty blocker study, one needed to have already completed the treatment with puberty blockers and have been cleared to initiate complete cross-sex reassignment. The Dutch did not consider puberty blockers to be a treatment. It was a diagnostic phase. They were considered to be fully reversible. And so there was a very high bar to be approved to start gender transition. And so all of the cases already completed the treatment were already approved by a multidisciplinary team doing extensive evaluations to say, yes, you are a good candidate, you're doing well. And then that cohort was taken, and the first 70 cases of those were taken. And so when you do a thought exercise about who would have made, or who importantly, who would not have made it into this first cases, it's anybody who developed problems while on puberty blockers and had to stop them, or who had ongoing doubts or perhaps increased mental health problems, because the Dutch clinicians were very responsible. They would have kept that patient in the diagnostic phase and continued to work them up. So in a way, all the problematic cases either had no chance of being included or had a much lower chance of being included, since the researchers took the first 70. So it's sort of your first race finishers are not representative of everybody who's in the race. And this theory, this is our hypothesis, we can't prove it, it's a thought exercise. But the latest reanalysis of the UK study, and I do point out that the Dutch study failed replication in the UK, even though it was closely matched, including looking at childhood onset of gender dysphoria. The adolescent onset was excluded from the UK research, and yet it failed to show any positive outcomes. But a recent reanalysis by Drs. McPherson and Friedman actually showed, as one would suspect when you see no improvement, when you dig deeper, there are clusters of patients who got worse, patients who didn't improve, and patients who got better. So that all averages to no improvement. And interestingly, a third got worse, and roughly another third didn't have improvements, and 29%, I believe, improved. So, and that is actually making me feel more confident in our original interpretation that this retrospective selection of the patients on for whom the Dutch reported on the puberty blocker experience actually excluded almost by definition those who would have gotten worse. And that is why perhaps everybody got better in the study. Or at least on average, they got better. That next level analysis of, who might not have gotten better was not reported. There is other limitations. Again, there's this notion of minimally important differences in evidence-based medicine. The changes were relative, when there were improvements on the measures, they were relatively small. It's not clear if they were clinically significant. Everybody reported mental health treatments, so there's a co-intervention. And notably, there is no reporting on physical health outcomes in those studies. We do know puberty blockers are associated with slowing and accumulation of bone mass, perhaps other problems as well. The study only looked at psychological outcomes, didn't attempt to look at physical health outcomes. Now, other Dutch studies did, and they did show that puberty blockers significantly negatively impact bone health. And it is not clear, that it's mixed evidence whether or not starting cross-sex hormones fully allows young people to return to the curves on, for the bone density that they were on. I want to point out that the second study is a missing study. So many adolescents today at least in America, starting straight with cross-sex hormones. There is absolutely no study from the Dutch team about the outcomes of the cross-sex treatment pathway. It was lumped together with surgery. However, there are some signals that perhaps some patients experienced harms during the treatment, because the subsequent surgical study says that 3 cases developed diabetes, severe diabetes and obesity, and dropped out. And it is not causative, but nothing in this paper is causative because there's no control group. It's an association, just like it was associated with some improvements in mental health outcomes. It was also associated with developing severe diabetes and obesity to the point where the patients were no longer allowed to continue on the transition pathway. And there's a report of one patient who dropped out of treatment, which perhaps we could call it a transition, but again, very little detail. The most important perhaps limitation is the final outcome study that is really the main study. And this main study inherits all the biases from 2011 because it's continuing with the cohort, and it adds a few more. Again, the patients with most severe outcomes, I do not believe it was purposeful. How do you report on mental health outcome of a patient who died from surgical complications? You can't, but the flip side of that is it appears that everybody thrived through the treatment protocol, and yet 1 out of 55 patients died, and some researchers postulated that it's actually a direct result of administering puberty blockers because they impact the available genital tissue. There's much less, so the surgery becomes more complicated, and so there are more complications. However, the main outcome is this linchpin finding that gender dysphoria completely resolved. So nothing else really mattered, because gender dysphoria went from almost the maximum possible score to almost the minimum possible score. And in our study, we took a look at that, and without really going into too much detail, I just I invite you to examine the scale for yourself and to recognize that at baseline, all the patients received questions according to their natal sex, but afterwards, after the final treatment, they got the scale of the opposite sex. So if you do a thought exercise and you think you're a gender dysphoric girl, and before the treatment, you have to say, I love, every time someone treats me like a girl, I feel hurt. That's item 2. And of course, a gender dysphoric female would say, of course, yes, this is what gender dysphoria is. But after the treatment, he would be asked, every time someone treats me like a boy, I feel hurt. And of course, that individual would say, no, all my life I wanted to be treated as a boy. That looks like a complete resolution in terms of scoring, but we argued if both sets of scales were given right at baseline before any treatment began, that same difference in score would have been there. And so that's your complete resolution in gender dysphoria. Another example of how the scale might have backfired is for questions specifically tied to one sex. So for example, item 10, I hate menstruating because because it makes me feel like a girl. Hating menstruation was actually considered a really strong predictor of a person being transsexual, girls hating menstruation. And of course, gender dysphoric girls would say, yes, absolutely, I hate menstruating because I feel like a girl. That's maximum gender dysphoria score. But after the person transitions, he gets the question, I dislike having erections. A female transitioner who had a mastectomy and testosterone has to answer the question, I dislike having erections. The answer is no, for more than one reason. And so that is, again, a complete resolution of gender dysphoria. So my co-authors and I continue to insist that the reliance of the scales on the scale to report the complete resolution of gender dysphoria is actually significantly compromising the linchpin finding of the study. We are not alone in our skepticism. The systematic reviews of evidence by NICE, the UK's National Institute for Health Care and Excellence, scrutinized these studies. The puberty blocker study, you don't rate overall study for certainty, you rate each individual outcome. So they looked outcome by outcome, and all the key outcomes, gender dysphoria and mental health outcomes, were rated very low certainty. Very low certainty means the effects reported in the study is likely substantially different from the true effect. And the post-surgery study was excluded from the NICE review entirely. The reason for the exclusion is that all the participants had gender-affirming hormones and surgery. These two interventions were conflated. There is no way to determine which intervention contributed. We add everybody also received mental health therapy. That was a co-intervention in both of the studies. And also complete data was available only on 40 patients. So we went from 70 to 55 and actually complete data on 40 patients. So this is the state of the foundational research that launched the practice. In our paper, we talk about newer research since, which has even more limitations. And this is the end of my presentation.